This is Radio Health Journal. I'm Reed Pence. This week, rethinking how many medical mistakes are acceptable.
We had been thinking about errors as the cost of what happens when people get health care. And then all of a sudden, it was reframed as, wow, this is a big disaster.
How do we get closer to zero when Radio Health Journal returns?
I'm Nancy Benson, host of Radio Health Journal. If you enjoy listening to Radio Health Journal, you'll also like our sister show, Viewpoints, which covers a wide array of topics from education to history to the environment. Here's a preview of what they're covering this week on Viewpoints.
You stay focused. I mean, if you've left only an hour to do it and your phone rings, well, you don't take the call. And now this thing you don't like is only in your life for 1 hour, not an hour and a half.
The art of productivity. Then,
if I know he had dysentery 5 times, if I know at one point he was riding with a pillow under his butt, now that is exciting stuff.
What you probably didn't know about America's founding father. I'm Marty Peterson.
And I'm Gary Price. These stories in depth this week on your public affairs magazine, Viewpoints.
Listen to Viewpoints on your favorite radio station and subscribe and listen to shows anytime on Apple Podcasts and Google Play.
Mistakes are an unfortunate part of medicine. Even for the most competent, up-to-date doctors, nurses, and technicians, opportunities for error are everywhere, and even the best treatments carry some risk. For a long time, we viewed errors in medicine as inevitable. But 20 years ago, an influential report came out saying maybe they're not. Maybe things are a lot worse than we think.
Things had been, I guess we could say that they had been horrible to begin with. It's just that we hadn't really been thinking of them that way. We had been thinking about errors as the cost of what happens when people get health care. And then all of a sudden, it was reframed as, wow, this is a big disaster.
That's Dr. Kathleen Sutcliffe, Bloomberg Distinguished Professor of Business and Medicine at Johns Hopkins University. She says the famous 1999 report from the Institute of Medicine called To Err Is Human declared a crisis in patient safety, even though it really broke no new ground.
The report itself was not preceded by a sudden rise in danger to patients. In fact, the report presented no new data from what had been gathered over the previous 2 decades. It merely repeated what had already been previously reported and what was known about harm to patients. And in fact, over the preceding decade, there had been many organized and substantive patient safety activities, such as more than 2 national conferences on patient safety that had occurred.
Even so, the report moved public concern unlike anything before, probably due to its use of dramatic language and a couple of eye-opening statistics.
In fact, it reframed the problem of medical harm into one of medical error, and then estimated that between 44,000 and 120,000 people died every year because people make mistakes.
So have we gotten any better in the intervening 20 years? Sutcliffe says yes, but we still have a long way to go, as indicated by the title of her new book, Still Not Safe: Patient Safety and the Middle Managing of American Medicine.
A recent report by the World Health Organization suggests that patient harm due to adverse events is one of the top 10 causes of death and disability in the world. And in fact, estimates suggest that in high-income countries, about 1 in 10 patients is harmed while receiving hospital care, for example. And rates of harm are even higher in low to middle-income countries. So it is a big problem. It's just a problem that a number of people had been attuned to and other people were not attuned to. And I think the value of To Err Is Human report really was to kind of put that crisis, if you want to talk about it as a crisis, on the central stage.
The report also came out at a time when healthcare was overcome with changes and new institutions like HMOs, institutions that often weren't run by doctors and so generated a power struggle.
Our research suggests that it arose at a time when healthcare was being challenged by cost and quality and safety issues, and when healthcare aimed to apply rational methods to address those challenges. I also think that it was a consequence of healthcare's growing awareness of and response to medical harm, The safety sciences, and when I say safety science, I mean disciplines such as psychology and organization theory and engineering, had also a progressive understanding of complex systems and the problem of accidents. And then, of course, there was a continuing litany of patients and families' stories of injury and suffering and loss due to the care that was intended to help them.
The Institute of Medicine report was ambitious. It challenged medicine to cut errors by 50% in just 5 years, by 2005. But Sutcliffe says that was never going to happen.
Unfortunately, it was unrealistic, if only because there's no consensus on what constitutes an error. And the exact number of deaths that occur in the U.S. because of errors and harm is highly controversial. There's no consensus on error rates or rates of harm. And even 20 years later, there is still no consensus on those things or on what is a preventable error.
Sutcliffe says another problem in creating solutions is that good procedures and people sometimes still produce slip-ups.
The majority of medical mishaps don't result from individual recklessness or the actions of some particular group. In fact, errors and mishaps, they unfold in the course of doing everyday work, and they're often caused by faulty systems or processes or conditions that lead people to make mistakes or fail to prevent them. So I think it's really important to remember that, accidents don't necessarily have special causes that are different from what leads to ordinary success. But the fact is that we really want to believe that. But the same mental processes that produce unusual success or usual success also produce occasional failures.
That's why Sutcliffe says we need to change how we look at patient safety. Too often, she says, we look only at what goes wrong. We also need to look at what goes right.
We're not suggesting that we don't look at what goes wrong. I would never suggest that, in part because I try to study the unexpected, and I know that getting a better understanding of our systems and how they're failing is really important for us to get a handle on the health of our system as a whole. But the fact is that things do go awry as we are working, and we're constantly making adjustments. We're constantly catching and correcting things, often without even knowing it. So it's really important to understand what elements are contributing to our ability to adapt, to our ability to cope, and our ability to recover. And I think that we need to understand how systems are going right in order to understand those things.
And when we look only at things that go wrong, we're also likely to place blame, the last thing people want pointed at them. So errors go unreported.
Nobody wants to screw up the record, and human beings like to think about their successes. Blame creates negative emotions and fear, which can contribute to people being silent, not reporting things, and the possibility that people will seek to hide their mistakes or mishaps as well. When things are hidden, there's no way to make them better. And we know from research that there are other consequences of blame as well. For example, people become unwilling to take any initiative at all, since if they make even a small mistake, they're going to get metaphorically hung out to dry. So this clearly lowers motivation to do anything out of the ordinary, as the consequences are unpredictable. I do think it's important for people to understand that when we talk about blame-free, it doesn't mean accountability-free. Holding people accountable and blaming them are two different things.
Given all that, Sutcliffe says improvements in patient safety have been piecemeal, but at least there have been improvements.
We have definitely made progress on many fronts. I don't think anybody would want to go backward. For example, we've made progress in reducing hospital-acquired infections that were previously thought of as the cost of health care. Still, infection rates vary widely, and so we have to think about that every day. There have been many improvements in surgical safety as well and in other areas, but you never get the safety thing behind you. Every day is a new day, and a good yesterday doesn't mean a good tomorrow. You have to do it all over again. And I think that it's sometimes a thing that people don't realize, that even though we have systems in place, that in my view, safety is an activity and we do it together. It is not a property of a system. It is something that we work towards through the actions that we take in our work every day.
However, the big things that would take a giant step haven't happened. Sutcliffe says we haven't made more sweeping changes that we really need.
We need to be looking not simply at the activities at the clinical level or the level of the single organization or healthcare institution. There are large classes of hazards that are going to require structural changes in healthcare as a whole. So these kinds of changes go far beyond multi-hospital systems at the higher social political level. For example, the issue of look-alike and sound-alike drugs, or the technological issues such as those little plastic things that connect healthcare devices to patients.
But whose lens should we look through? Who should be making the decisions about what we need to do? Maybe no one group should win control over doing something about healthcare. All the players have their strengths and weaknesses.
Each discipline has a way of seeing problems and a set of tools to solve them. When you have a toolkit, you want to use the tools that you have. And you can also say that, a way of seeing is a way of not seeing. And healthcare providers, they fix people, and they generally don't fix systems. But they wanted to fix everything.
But to do that, medicine will have to call in experts from a lot of other fields and be willing to give them some authority to do what they know how to do.
Patient safety should be more diverse. We really should take seriously John Sender's warning that medical errors and the adverse events that sometimes follow are problems for psychology, organization theory, and engineering, not just medicine. So engaging expertise from a broad variety of disciplines, I think, will add to our understanding of how people in complex systems make sense of and update their understanding of unfolding events in the context of their everyday work. But that sounds simple, but it's very hard because getting people together and getting people to share particular perspectives is very hard work, and it takes a lot of interaction. And people in healthcare naturally want to implement ideas right away because they're very concerned of negative outcomes.
In the end, however, even if we make tremendous progress on patient safety, we come back to the question we started with. How much medical error is inevitable?
One of the things that we have to confront in the beginning is to really confront the difficult question of how safe can we realistically be. I think aspirational goals are really important. But there is a danger that the rhetoric of perfection really prevents important discussions about the realities of everyday clinical work. Complex systems, as you said before, have elements of unpredictability, and there always are going to be new risks and dangers that we didn't anticipate. So I think we need to really start there and talk about that.
You can find out more about all of our guests on our website, radiohealthjournal.org. You can also find archives of our programs there. You can also follow us on Facebook, Instagram, and Twitter. I'm Reed Pence.
Most primary care doctors expect to see more people with dementia over the next 5 years. But a new survey shows half of them don't think the medical profession is ready. Primary care physicians are on the front lines of dementia care, but nearly a third are never or only sometimes comfortable answering patient questions about it. Nearly 2 in 5 say they're never or only sometimes comfortable making a diagnosis. That's deeply concerning to Dr. Joanne Pike, Chief Program Officer of the Alzheimer's Association.
We're heading toward a medical emergency when it comes to ensuring dementia care will be available for all who need it. It's critical that stakeholders work together to reverse the shortage of dementia care specialists and enhance dementia care education for primary care providers.
The survey is part of the Alzheimer's Association 2020 Alzheimer's Disease Facts and Figures Report, which finds that, barring medical breakthroughs, the number of people with Alzheimer's dementia may nearly triple in the next 30 years. Find out more at alz.org.
A new study shows that increasing the number of steps you walk each day can have significant health benefits. Researchers followed middle-aged people for 9 years and found that those who walked the most steps per day had a 43% lower risk of diabetes and a 31% lower risk of high blood pressure compared to those who took the fewest steps. Women with the highest step count were 61% less likely to be obese. Among the men in the study, there was no association between steps taken and obesity risk. Dr. Amanda Paluch of the University of Massachusetts was lead author of the study.
Walking Walking is a widely accessible form of physical activity, and steps per day is an easy measurement and motivator. Accumulating steps throughout the day is a less daunting way to be more active than, say, a daily extended exercise routine. Every step can help to make a difference.
Researchers now want to see if walking speed can impact heart health risks. The study was presented last week at the American Heart Association's Epidemiology and Prevention Lifestyle and Cardiometabolic Health Scientific Sessions 2020.
And that's Radio Health Journal for this week. Radio Health Journal is a production of MediaTrax Communications. Follow us on Twitter, Facebook, and Instagram to learn more. And check Apple Podcasts, Google Play, and Spotify for a library of past programs. Plus, you'll always find previous segments and information about our guests at radiohealthjournal.org. Join us again next week for another edition of Radio Health Journal.
Coming up next week on Radio Health Journal.
OBGYNs historically did not get any training in psychiatry. So when you were pregnant or lactating, where did you go? And a lot of women survivors will describe really having felt abandoned or in a place where they felt like nobody wanted to care for them.
Improving treatment for perinatal depression.
Then, will fighting coronavirus really change public policy?
These very divisive, long-argued issues are not going to change because of this epidemic. I could see some people thinking, oh, it's a tail wagging the dog.
All that and more on Radio Health Journal.